Great to see everybody. My name is Walt Whitley, and I am the Director of Optometric Services at Virginia Eye Consultants in Norfolk, Virginia. Today we've heard a lot of great talks so far. We talked about the diagnosis. How do we determine which patients have dry eye? We've talked about MGD and where does this fit when it comes to our patients, and we know the high prevalence rates when it comes to meibomian gland dysfunction. When to refer, how to co-manage these patients. Jerry did a great job talking about that. When you're at the tables tonight, go all in. It just takes one time. But when it comes to therapeutic treatment options, we know there are several options available. We know that there was the International Task Force that provided guidelines for mild dry eye, moderate to severe, and we're going to talk about how we can utilize the different treatment tools within our practice. Here's my practice. We are a tertiary referral care practice. We have 17 providers, cornea specialists, uveitis. We have all the specialties within our practice. So my role within the practice, I do see patients several days out of the week. I'm involved with clinical research, several of the studies that I'll share with you today. Education, as well as running our dry eye clinic. Trying to make sure that for those of our docs that already embrace dry eye, that they are engaged and involved. For that retina specialist or glaucoma specialist that have heard of dry eye but doesn't treat the dry eye, establishing protocols in place with our team, with our doctors, identifying patients utilizing the speed questionnaire, as Mark mentioned earlier, utilizing tests such as tear film osmolarity. We have a sign, we have a symptom, and then referring those patients to one of our docs that do the treatment for our patients with dry eye disease. Why is this important? How can we optimize our practice? We know that the patients win. They've been suffering for over 6.5 years. Oliver Shine out of Wilmer, he wrote this in a paper several years ago. They've tried over three different artificial tears. If they're coming to us with a sign or a symptom, we need to make sure that we are prescribing for our patients to address this disease that they've been suffering from for many years. The insurers win. We have targeted therapy. Whatever treatments that we utilize are going to be specific for that patient and whatever form of dry eye disease they have. The doctors win. The practice grows. Why? Because we treat Mrs. Smith. She'll tell her friend, her neighbor, and you're going to get more referrals by aggressively treating the ocular surface and helping our patients with a quality of life issue. And that's where the practices win. Income diversification, utilizing cash-based services, elective procedures to help grow our practices, especially in this healthcare arena. We know we're seeing declining reimbursements, but what are some of the other tools that we can add to our practice? How do we use diagnostics in our treatment? If we utilize the LipiScan or the LipiView, we can identify patients with meibomian gland dysfunction. We can show them their atrophy within their meibomian glands, and we can make a recommendation for the LipiFlow or MeiboFlow or IPL. What about inflammation, matrix metalloproteinases? We may need a steroid if it's positive. Or if we feel our patients need punctal occlusion, we're going to want to hold off on occlusion until we get this inflammation under control. And then tear film stability or instability. Looking at the homeostasis of the tears, whether it's with tear film breakup time or using objective measures such as tear film osmolarity. And as you can see in this graph, once you get this patient, Mark talked about this earlier with that number, once you get control of the tears and the tears are in proper homeostasis, you're going to see that number go down. And it's going to stay around 300 milliosmoles. We're following our patients every 3 to 4 months, maybe every 6 months. We'll do an osmolarity. If the osmolarity goes up, what do? We do something. Whatever their treatment is, that's their baseline treatment, we may add steroids, add plugs, but do something. So utilize these tests for our treatments. As Whitney mentioned earlier, several different devices are available, and these are the packages that we provide at Virginia Eye Consultants. This was the Dry Eye Summit, and from the summit, the baseline management for all of our patients, prescribe lubrications, prescribe lid hygiene, prescribe nutraceuticals, as well as anti-inflammatories, because as I mentioned earlier, patients have tried 3.5 artificial tears. They want something that's going to address their condition. Premium tears. 86% of patients with dry eye disease do have the evaporative form. So a lipid-based tear may be the best tear for our patients. Or an HA drop, looking at the viscoelastic properties of the drop, the shear thinning, that's going to help stabilize the tear film. Bring the heat. Prescribe a heat mask. We know that we need at least 104 degrees temperature for at least 4 minutes to soften the obstructions within the meibomian glands. But typically when we prescribe this, we're going to have our patients do it for 10 minutes. Why? To help them produce better lipids. Clean your lids. Great, we love the ocular surface. We love glaucoma, we love retina, but we can't pass the lids, and we have great treatments that are available already, whether it's seborrheic blepharitis, staph blepharitis, or Demodex blepharitis. Clearadex Lite is something that has come out that can address patients that do have Demodex. Let's look at the pipeline. And when we're looking at dry eye disease, it is inflammation, whether there's aqueous-based or evaporative-based, inflammation does play a role. Looking at the future, whether it's new drug delivery systems, whether it's new drug molecules or designs, inflammation is what the drug companies are targeting right now because it does have a significant role. Nutraceuticals, more knowledge, more questions. We know to prescribe a nutraceutical, but whenever we're prescribing, we know we do have many options that are available. It's important to look at the data utilizing evidence-based medicine. What we want to do is we want to make sure whatever studies that for whatever we're prescribing undergo randomized controlled trials that are placebo-controlled, because if you're not placebo-controlled, of course you're going to look better. But we want to make sure we're looking at the science. The omega-3s, the omega-6s. We know about EPA and DHA. Is it 1,000, 2,000, or 3,000 milligrams? Milton Hom and Penny Asbell, they're doing the DREAM study where they're looking at 3,000 milligrams of fish oils because of the anti-inflammatory role. But one thing that we can't forget is the omega-6s. Omega-6s get a bad rap. We hear about the inflammatory portion of the omega-6s, but there is a specific omega, the GLA, gamma-linolenic acid, that is very potent and site-specific for the lacrimal gland and the ocular surface. This was a study that we were involved with in our practice, the Hydro Eye study. 38 postmenopausal female that were on this for 6 months. In this study, we were able to address a sign, which is going to be the inflammatory mediators of the HLA-DR and CD11 cells, but we were also able to address the symptoms for our patients, decrease in the OSDI scores, and so this is what we do prescribe for our patients. Looking at inflammation, we're all familiar with Stasis. It's the first dry eye medication to come out, and we all continuously use this within our practice. Why? It addresses inflammation, but it does work on all 3 layers of the tears. It has castor oil to help the lipid layer. We know in the SOL study and the pivotal trials increase in tear production, but also 191% increase in goblet cell density. So working on the mucin layer. We know that that's a medication that we utilize for our patients that do have dry eye disease. But sometimes they may need induction therapy, and that's where the Asclepius panel came in, looking at the role of anti-inflammatory steroids, pulse dose the patient, put them on cyclosporin, and then now we may need to, we're going to see how it works with Xiidra as well, but addressing the acute inflammation and helping the patient for this chronic disease that they have. That brings us to Xiidra. We were involved with Opus 1 and Opus 2 to get lifitegrast approved. And what Xiidra is, it's the only medication that's approved for the treatment of the signs and symptoms of dry eye disease. And so there's this protein called ICAM, which is found on the corneal epithelium. We know that there's this LFA agonist that is going to be on the surface of the T cell. And so what Xiidra does, it blocks that interaction and does not allow that to bind together to release the inflammatory mediators in the eye. This has been studied in over 2,300 patients. In 4 of the studies, it improved the symptoms in 6 weeks. In 2 of those studies, it improved the symptoms in 2 weeks for the patients. What about the signs, the inferior corneal staining? In 3 out of the 4 studies, it did show a decrease in inferior corneal staining for patients that were put on Xiidra. So it did address a sign and a symptom, and it's something that we're all going to have to utilize. It's great we have great treatment options, but more treatment options to offer our patients. And so, so far I've seen a couple patients back. They've been very excited about this, and they say this has been an exciting treatment for me and my dry eye. Don't forget plugs, underutilized. About 3% of Medicare patients do get punctal plugs, but this is something that we can use for the chronic condition that our patients suffer from. With the punctal plugs, Balaram did a study, 50 consecutive patients. 86% of those patients did get symptomatic relief from plugs. So don't forget to utilize these because it's a great option for our patients. What about azithromycin and doxycycline? This was another study, 110 patients. We know that this can address inflammation in the meibomian glands. And what they found, because of the simpler dosage, the 5-day dose of the azithromycin, may be an effective treatment option for our patients for their symptoms, but also addresses the conjunctival injection that the patient has and smooths the corneal surface. What about Procara? This is something anti-angiogenic, anti-inflammatory, anti-scarring. This is something that we can utilize for our patients with moderate to severe dry eye disease. And if we look at the studies there, patients can get anywhere between 2 to 16 months relief and improvement in their signs and symptoms of dry eye disease. And so this is something else that we can utilize. For patients that had one Procara, they were able to decrease their drops from about 2.3 drops to about 0.7 drops. And so try this. See how this works on your patients. But that's what it comes down to, is dry eye is a prevalent condition. It's a progressive condition. It's important for us to manage our patients, not just short term, but long term. We need to consider all forms of dry eye, whether it's due to MGD, whether it's due to aqueous deficiency, but understanding there is an inflammatory role and treating that accordingly. And as Jerry mentioned earlier, it's important for us to establish ourselves as the dry eye expert and be there as a resource for our patients in our communities.